Hi everyone. In today's 5-minute medicine capsule, we are talking about hyperkalemia, a potentially life threatening electrolyte disturbance that's important not just for exams but also for saving lives in the ER. Normal serum potassium is about 3.5 to 5 millimoles per liter. Hyperkalemia is when it rises above 5.5 millimoles per liter. Remember, potassium is mainly an intracellular ion. Even a small rise in serum levels means there's a big shift happening inside the cells. Let's divide the major causes into three categories. The first one being increased potassium intake, which is rarely the sole cause, but it can happen with potassium supplements or a high potassium diet in patients with kidney issues. Secondly, shift of potassium from the intracellular space to outside in the blood. This can occur in acidosis or in any other cause of tissue breakdown like burns, rhabdomyolysis, hemolysis, insulin deficiencies, beta blocker, anything. Thirdly, being reduced potassium excretion. This can occur in patients with chronic kidney disease, acute kidney injury, hypoaldosteronism, potassium sparing diuretics like spironolactone, ACE inhibitors, and ARBs. We need to understand why hyperkalemia is so dangerous. Potassium controls the resting membrane potential of the cells. A high potassium level reduces the difference between the resting membrane and threshold potentials, which makes the cells, especially the cardiac myocytes, more and more excitable at first. Then eventually, the cells become unable to depolarize altogether. This leads to fatal arrhythmias if left untreated. ECG changes progress as the levels of potassium rise. In cases of mild hyperkalemia, we can observe tall, tented, narrow-based T waves, best seen in precordial leads. In moderate hyperkalemia, we can observe widened QRS complex, a prolonged PR interval, and flattening of P waves. In severe hyperkalemia, we observe a sine wave pattern, which is a medical emergency. Ventricular fibrillation can occur, and ultimately, the patient can land in asystole. The patients may have muscle weakness, paresthesias, flaccid paralysis, but remember, the symptoms don't always match the danger on ECG. You can have a normal looking patient whose heart is moments away from arrest. The management of hyperkalemia can be summarized in three major steps. The first one being, and the most important one being, is to stabilize the heart with IV calcium gluconate or calcium chloride immediately to protect the cardiac membrane. Next, we want to shift the excessive potassium back into the cells. For this, we use insulin in combination with glucose as we don't want the patient to land in hypoglycemia as well. We can use nebulized salbutamol, sodium bicarb if acidosis is present. Lastly, we have to remove the potassium from the body itself. For this, we can use loop diuretics, cation exchange resins like sodium polystyrene sulfonate, or dialysis in severe or refractory cases. An emergency tip: if you see ECG changes, don't wait for lab confirmation. Start treating the patient immediately. If you found this helpful, hit the subscribe button for more 5-minute medical explainers and drop in the comments which topic I should cover next. Thank you.